Thank you, Jenny. I will point out that even though the insurance companies are the one who's paying that amount, since we only get a lump sum now from the insurance company for diagnosis X, any cost that you can save actually does save money for the hospital. So just kind of put that in perspective. So we have a visiting professor today, and I'm thrilled to be able to introduce to you Dr. Richie Cantorr, professor of emergency medicine and pediatrics, who's come to us from Syracuse, New York. I don't know if any of you remember, but I did my residency and medical school training there, so I know Richie very well. But I did look through his CV to find out a few things. So Dr. Cantorr received his undergraduate education at the State University of New York at Buffalo with a major in biology. He went to medical school at Upstate Medical University in Syracuse and then also stayed there for residency in pediatrics when Dr. Frank Oski was the chairman of pediatrics. He later did additional training in toxicology, like many pediatric ED folks in those days. Richie was originally certified by the American Board of Pediatrics, but then has maintained his board certification in emergency medicine and in pediatric emergency medicine. He has spent his entire career at SUNY Upstate. He ultimately became the medical director of the Poison Control Center for Central New York, the director of pediatric emergency services, and the director of the Pediatric Emergency Fellowship. Richie became professor of emergency medicine and pediatrics in 2010. Dr. Cantorr has several dozen papers and at least 28 textbook chapters. He also has been the editor of 4 textbooks on pediatric emergencies or clinical toxicology. He's a frequently invited speaker at the national and international level. Richie served on the sub-board of pediatric emergency medicine for over a decade and was both the chairman of the AAP section on pediatric emergency medicine and was the president of the Society for Pediatric Emergency Medicine. He is currently on 8 editorial boards. I did not invite Dr. Cantorr to Charleston. Our peds emergency medicine folks did. They kind of said, yeah, we're thinking about, do we have the money to invite this pediatric emergency medicine guy's name is Richie Cantorr. I'm like, Richie Cantorr from Syracuse? Yeah, Richie Cantorr from Syracuse. So, but I think I'm doing the introduction because I already knew Dr. Cantorr from my previous life in Syracuse. And not only did we overlap there, but I don't know if you remember this, but I did my acting internship as a third-year medical student in the 8th block of the third-year medical school. And Richie was my first floor attending. In those days, some of you are too young to know this, but they made everybody do like what the hospitalists do now, except the neonatologists. They didn't have to do it. So everybody took their turn as the floor attending, if you will. Now we have hospitals to do that, so Richie can just stay in the ED. But it was... So Richie was my first attending. The first death of what I considered my own patient as an intern, you actually own your patient, was actually on that rotation. It was an 8-year-old girl with cystic fibrosis, and he was there to help guide me through that process. And so I learned a lot from Dr. Cantorr. And yes, even when you are a busy floor attending, you can give the house staff lectures. And I saw from him that you can be a teacher and a clinician and still be a real person, and that you can have fun and still be a teacher and a clinician. So, of course, I later had many more experiences with Dr. Cantorr when I worked in ED. He was one of those faculty who was essentially liked by all trainees. And I look forward to hearing him speak today on advances in pediatric emergency medicine, what we see, what we do, and why we do it.
Thanks, Rita. It's nice to be in another state. I'm from New York originally. I've been in the tundra forever. It was snow on the ground yesterday when I left Syracuse. That's just not normal. I'm thrilled to be here, mostly to see the city, to see the facility. The EM people here know what they're doing. We're going to go over that. My choice of topic is really a combination of sort of like the greatest hits of what peds emergency medicine has been doing, and also to get you to embrace the care that happens on the first floor and unify it with what you do upstairs. We all work in our little environments, whether it be NICU, HEMONC, or whatever, but be nice to the other guy, and you'll find that things go very well. How many of you are residents? Okay, so I have to be PC and kind and considerate, and I'm in South Carolina, so that's the end of my talk. Okay, so first I want to take a trip down memory lane. Seems like only yesterday, Dr. Ryan, that it was 1986 when you left us and graduated rather, from the residency. These were not a good era, Rita. We had Madonna, come on, George Michael, Kiss, and the Mets. I just put that in for me. Our chairman then was Frank Oski, and that's a cake we made him. It had he was a big breastfeeding proponent, so it was a big deal. Our softball team was called Mother's Milk. We actually had a softball team called Mother's Milk. We played in the downtown league with some pretty rough trade guys, and it was kind of weird to wear Mother's Milk. Anyway, Frank was, I don't know if anybody ever heard of him. We're too old to remember, but Frank was the smartest guy on the planet, the meanest guy and the nicest guy. In his lucid moments, he was a miracle worker. And a lot of us who came from Frank are chairs and other things. So we were blessed to have the right leadership, and you have that as well. There was also this young lady, Dr. Ryan. That's not beer. This is Rita. Do you believe Maria wore those shoes? And no, that's... Oh, Maria. Yeah, yes. I knew talent when I saw it. When Rita came to the floor, she was young, who wasn't then, and she just had a combination of brains and testicles. She was... No, we just... Guys, it's New York. You're going to deal with it. It was one of the joys of my life. And this is just a good person and a good doc. So it's a good time to think back on. So anyway, let me get started here. I speak quickly. There's going to be rapid fire events here at PZM. EM people in general have no attention span. You know that, right? How many of you think you have no attention span? It's true. My wife just said something in Syracuse, and I'm already bored by it. Okay, you don't want to live with people like that. So what am I going to do here? I have no disclosures. Who wants me to represent their product? All right, this is it. The same old thinking, the same old results. If there's one piece of advice I can give you in your life, is to just rethink what you're doing all the time. It's really comfortable to do the same thing. I thought the lab thing you went over was wonderful. The advice I would give you with lab work, I always tell my residents, is don't tell me what you're ordering. Tell me what you're going to do with it, with either normal or abnormal, and then I'll let you do it. And that's probably the best thing you can do. You all have Epic down in the ED, and you can just click away on those tests and stuff. Just a little restraint. So I thought that was very pertinent. And that's coming your way career-wise. Rita's right. We're not getting any more money from anybody, so keep it in mind. Okay, so here's some quickies. Topics we're going to go over. ID complaints, respiratory issues, ALFIs, the irritable infant, management of gastroenteritis, belly pain problems, child abuse and neglect, useful new procedures, parental presence, and pain management. Those are just highlights of things that have happened in PZM over 30 years that have changed. So let's talk about the febrile child. 7,000 fellowships were built on fever, looking into fever in the 80s and 90s. Then we made a mistake and we immunized. Whose idea was that? Anyway, do you have people down here that don't immunize? Not so much? It's Ithaca. I got Ithaca. We have a big thing in Syracuse, and I always tell parents, it's your right to not immunize your child murderer, but it's your call. All right, once upon a time, everybody under 30 days who had a temp got a bed, a septic workup, and admission. Well, what's changed? Here's a study that is going to scare you. They wanted to predict serious infections in kids based on duration of fever and how the labs shape up in these kids under 30 days. Let me show you what I'm getting at. They wanted to look at numbers on white count, CRPs, ANCs, in relation to how long they had the fever. You'll see what this means on the table in a second. These are kids under 28 days who were hospitalized. Don't glaze over. There's not a lot of data. And then they redid the labs after they admitted them to see what we already know about kids under a month. You cannot trust them. Their immune systems are sluggish, they're non-discerning, and they're not dependable. And if you take a look, big penetrance, quarter of the kids had serious bacterial infections, only 100, but take a look. The CRP, the absolute neutrophil count, the white count, initially under the receiver curve, higher numbers are better at 12 hours. The take home here is basically you can't trust the lab results in the ED. You don't know where you're catching the numbers on the sick babies under 30 days. So, present day, temp is listed. This is never going to change. It's never going to change. You are always admitting, poking holes, and buying beds and giving drugs. The only way you can change this would be like a study of closed head injury where I designed it, dropping kids from heights. I mean, nobody's allowed to miss one septic baby under 30 days. You can't do it. So that's not changed. I'm sorry to upset you. First thing I'm telling you is nothing's new. That's life. Second, all infants less than 3 months with a temp greater than 39 got a tap. Rita, remember all the taps you did? How many of you are PG3s, third years? And how many of you in that third year group have done more than 20 taps? We're done, okay. I did more than 20 taps in my first month in the, we used to tap everybody. Anyway, and the white count and the neutrophil count were used to see who got antibiotics. We used to do this. Here's a study, 2 quickies, prevalence of occult bacteremia in kids the typical 3 months to 36 months. What is the prevalence of occult bacteremia? They just want to know what is out there. This is important. They found, retrospective study, 3 years, they were included kids basically if they were under 3 months, 3 years rather, and they went home and were well appearing and had a blood culture drawn. And if you look at their numbers of what they got back, 8,000 kids, there were only 21 true positives, a rate of 0.25%, and 159 contaminants. And the contaminant rate was 1.89%, and you'd get 7.5 contaminants for every true positive. When I trained, and the computer would come to life the day after you saw a kid, a blood culture would be growing. And it was terrifying. You'd call the kid at home and say, hey, is Billy alive? Squeeze, shake him, squeeze something on his body. Remember the callbacks, Rita? Those are my scariest mornings. The message, it may not be cost effective to poke holes in these kids. Let's keep going on that one theme. Labs in kids, and this is where we are, the state of the art. They did a survey about 5 years ago, and they wanted to see what are people doing out there? Who's giving ceftriaxone? Who's getting films? Who's getting blood cultures and UAs? And they wanted to see 2 specific targets. Who's getting white counts? Who's getting urines? And basically, being female, having a higher fever and higher median income were associated with labs. We are nowhere on fever workup on 3 months to 3 years. It's individualized. We have immunized, thank God. We have lowered the incidence of bacteremia. You're going to have to individualize it. And more to come. PCARN is going to do more studies on it. How about meningitis? We used to tap everybody. It was just the way you rolled. Remember this? Once upon a time, you could rely on symptoms and signs for diagnosing meningitis. You also performed a spinal tap. The fetal position was most important. Who is the most important person in that room to dictate the success of a holder? We had this little emphysematous nicotine-laden midget named Carol, Grandma Carol, who could hold any baby better than succinylcholine. I mean, she could just... And no, that kid didn't move. You missed, it was on you. The problem is he didn't walk for about 3 days, but we won't get into it. So here's the 2 dictums. First study, diagnostic accuracy in looking at kids with meningitis. And they did an analysis of kids under age 16, and little pleocytosis is the tipping point, 108 kids, mostly viral, and they look at their numbers here. The complaints are listed, headache, vomiting, and photophobia. The sensitivities are listed, and the specificities. It's horrible. And if you look at findings, stiff neck, Brzezinski-Koenig's triad, and then a bulging fontanelle, this is terrible. So the conclusion here is limited value. And I think it's the same old line that you're going to hear about a lot of tests, that if you're driving home from a shift and you say, I should have tapped that kid, you should have tapped him. And I always tell my residents, even if I don't think the kid needs a tap, I'm sort of old and burned out, I let them do it. You need to establish your own parameters and do taps on people, because you need to get good at them and you need to increase your threshold. But you don't want to be the guy who graduates a residency and say, hey, Dr. Ryan, I did 120 taps in my residency and 110 were positive. Everybody get the point of that? You should have done like 1,010? All right, you're there. Okay. The second thing, this is my favorite study, positioning for LPs by bedside ultrasound. You do ultrasounds in the ED. The best studies in the world cost $1.50. Don't use radiation, don't hurt people, and get concrete information in a hurry. And this is a study that they did where they looked at 3 decubital positions for babies, straight up, flex at the hip, bend the head, that's the Carroll method, and then sitting and flexed. And they wanted to see which was the best one by ultrasounding the back and getting intraspinal muscle spaces and see where the spaces are. This is beautiful because it's easy, right? Always the best study. So what they find, basically just flex the hips in the sitting position and stop bending the neck. It doesn't do a damn thing for the interspinal space, which I think is very valuable because there were studies in the 80s and 90s where they did OSATs on these babies that we folded and they just didn't ventilate. So they may not have meningitis, but they're not going to get the best SAT scores. So we don't want to do that. So I love these two studies. Let's talk about febrile convulsions, and I like what the AAP put out about what to do for these. In the old days, all kids who got a simple febrile seizure should get a full septic workup, EEG, CT scan, probable admission. Sound familiar? 22% of the chief complaints in my pediatric emergency department start with the word needs. Needs CT scan, needs EEG, needs MRI. Now, I don't want to piss and moan, but it's replaced ATP as my substrate. But the reality is, it's happening from primary care offices who are telling people you got to go there to get this stuff. And it's out of hand. If I have time, I'll tell a better story. But anyway, good news. PEDS said, the subcommittee on febrile convulsions says the following. These investigations, labs, taps, all this stuff, stop it. Just find out where the fever's coming from. Get a urine. Think about meningitis if anybody who's not been immunized. And this isn't a joke. If somebody's not been immunized, all bets are on. You're going to do a lot more to somebody. And make sure you ask the question. Conclusions, if they're pre-treated with antibiotics, you worry about anything, you do not need an EEG or neuroimaging. And just say no. CT scanning is obviously not indicated because of the radiation. But you have peds neurologists here, right? We got a couple of new ones. They wanted me to create 2 rooms in the peds ED for EEGs. I didn't do it. I said I'd get right on that. Imagine doing EEG. Do you do EEGs in your ED? No, I only do them when the electrical activity has to be diagnosed. I don't want to do it routinely because you know what's going to happen. So you got to be careful. All right, what about UTIs? If I get stranded on a desert planet with 1,000 febrile kids, I need cath urines. How many here remember suprapubic urines? Anybody ever do them? All right, so for those of you who are much better looking, suprapubics are a 5 cc syringe, maybe 10 cc syringe with a 22 gauge needle. You take some betadine, you feel the symphysis, you rub the betadine just above it, and you put your finger there to mark it midline because the bladder is an abdominal organ. And as you're doing this, you do 2 things. You turn around to the parent and say, this is no big deal. And you tell the kid, look, a baby wolf. And then you go in. And that's what we used to do. Going right to hell for that. We've evolved. Now I just don't tell the parent anything. But we just did one on a kid. And my fellow was so excited that we did a suprapubic. But he comes in with the ultrasound, which is an unfair fight. So, but use the ultrasound. Anyway, okay. A word on urines. The duration of fever matters. You are all trained in, whether it be neonate, you're like twin children of different parents. Everybody gives you their rationale for doing crap. And, you know, it reminds me, I used to go swimming a lot, and I grew up on the ocean in Long Island, and there were like rules about when you could swim after you ate. If you ate a lunch, how long do you have to wait? If you had what did you guys get told? An hour. There was always some I had a crazy old Jewish uncle. He was the arbiter of waiting. I would say, I want to go swimming. He said, what'd you have? I said, a pastrami sandwich. This is an hour. What'd you have? You go, an apple, like 12 minutes. And what would happen to you when you went in the water? You would die. You would crumble up because all your blood supply. So everybody's been telling you about urines. And there is some rationale to not getting a cath urine on the first day of a high fever and no source. They did a study design on 800 kids, the usual age groups under 3 years, and they wanted to know how long you had the fever and where are we going. Now they did, don't shoot the messenger, bag dipsticks, but they also did cath urines. What is the only indication for a bag urine? To induce anuria. We can do an experiment. Keith and I will do an experiment today. We'll put a bag on each other. Well, you can put yours on, I'll put it on, and see who pees first. I'm not peeing until Flag Day. Anyway, so bags. But let me show you what I'm getting at here. The bag urinalysis, the positives increased from 14 to 26% on day 3. And these actually were reliable. You can get a reliable bag specimen if you don't have any cells, if you got lucky and you cleaned it enough. I don't want to be too crazy. But here's really where all the answers lie. 5% on day 1, 12%. So there is a rationale for getting more urine cultures on day 2, 3, 4 of fever, no source. And I think that makes total sense. What else? This is what I want you to do tonight with your loved ones. Try a new technique for getting babies to pee, and you catch it midair. You hold the child up, one person credays the bladder, while the other rubs L2, 3, 4, and you catch the urine. Okay, guys, he's writing it down, it's good. So they wanted to see getting a urine, and that was the end of that. Hold on. Okay. 86% of the time it worked. And it's just, I threw it in there for fun. We've been doing it, and what's that? Girls too. It's awesome, Rita. It's great. You clean them up, do the right job, hold them up. Parents love it because you're not, cats are no fun, etc. So I just threw that in. All right, so present day UTIs, I'm not going to bore you. Everybody with a fever, no source, there's a lot of different rules. First 24 hours, you can argue it. As they get more febrile, more longer, go for it. And one of the things we got to teach everybody is if you get a positive urine on a baby, it's not a cystitis, it's a pyelo. And that's why you have to take it seriously. So, but I think you all knew that. Okay, let's keep moving. Inflammatory markers. One of my favorite things is when I get a septic knee or hip or whatever, and the ortho guy tells me what before he'll come down and see. What labs do I have to get? CRP, ESR. Does he have any clue what they stand for? No. So when they come down, he'll say, well, what was the CRP? I'll say, well, the CRP was normal, but the GRP was elevated. And he goes, really? I said, there's no such thing as a GRP. And that's my singular moment of triumph as he leaves and goes to the gym and makes more money than me. All right, once upon a time, we did markers. Did you guys do these in the NICU? All these counter-immune, remember the counter-immune electrophoresis stuff? I remember it. And there were surface antigens, and yeah, we used to do all this stuff. And not good. They had too many false positives, a lot of, not good. So in order, this is of what's out there in the last 10 years, this is only 10% of the titles. A score. Procalcitonin versus C-reactive protein. It's like Godzilla versus Mothra. Procalcitonin in picking up bacteremics, a meta-analysis. The utility of picking up bacterial pneumonia versus viral, using it. And finally, we wrote an article doing a meta-analysis on the meta-analysis, and the answer is they're only helpful if they're normal. If I have normal numbers, I feel good about America. And we'll see how this works with appendicitis and other things too, but we're not there yet. We have a lot of issues with this kind of thing. Croup. When I was growing up, we had mist therapy. And if somebody got a epinephrine, they had to stay because it bounced back Strider, okay? So we did a study. They actually did a labeled radioisotopic study on mist. And I don't know how they got it through the IRB, but they did scintigraphy to see how far it got down in the lungs. And basically, giving mist, that's a croup tent. You guys don't. So when I was training, I was making rounds with Dr. Oski, who was, as I already alluded to, brilliant and abusive. And it's just the way it was. He once said something to me on rounds. He said, tell me you're better, and forgive me for this, at screwing your wife than screwing up my patients. Sound like Frank? So I said, Frank, I stink at both. And he goes, I knew it. All right. So we're making rounds one day. Actually, it was fun in retrospect. This is a croup tent. You put the babies in it, you have the mist. So we're making rounds, doing floor rounds, checking people in the rooms. Remember that? Touching them. touching them, you know. So I'm standing in front of this mist tent. Dr. Oski goes, how's this kid doing? I said, I just checked her. She has no stridor. She's really doing well. And I unzipped the tent. She's not in it. Because she was in the playroom because I couldn't see her from the mist. How did we ever get through to residency? Well, what Dr. Oski did, I have to tell you, is the people he picked on the most, he took the best care of. So anyway, I'll keep it. So enough with the mist. Stop it. And it's really a cold pack for the throat. Let's get to the point. And luckily, I live in a cold climate. In Croup, half the time they get on the ride in, they get a lot better from cold temperature. And vapenorephrine, it's safe to send them home after 2 to 3 hours because they've gotten a steroid, which is indicated. And you can use 0.15 per kg. It's whatever article you read. And Croup should be leaving. But if somebody gets Vapo a few times in a 2-hour period, they're in-house. Number 2, think what they might really have. Number 3, I have an old wives thing. I don't like stridor during the day. I get nervous when kids are barky daytime. Night makes total sense, but keep it in mind. And Croup is annoying me. It used to be a Halloween disease, and now it's all year because it's multiviral. Actually, everything's breaking rules now. Forget it. Anyway, okay, Kawasaki disease. We own this in the PZD and the office setting. We own this disease, this illness. And I'm thinking back to all 5 million kids with fever for 6 days that I did 3 taps on and didn't do anything when I was training and missed this. I'm very serious. And you all know about Kawasaki's. I'm not going to bore you. But once upon a time, you could depend on the basics. The high fever for 5 days, being very annoyed, big red eyes, big red lips, cracked tongue, that kind of thing, maybe a note or two, and blushy red skin. You memorize this on the boards. You know it's cold. Well, everything old is new again. Kids less than 6 months, they found it. There's a billion studies on this. They found 120 patients with Kawasaki's, and they looked at a group, 17% that were under 6 months. And let me get to the point. Their white counts were different. Their platelet counts, which we do rely on, were different. Their triglycerides were different, and the high drops were much different as well because you had late diagnosis. So you really, really have to keep your eyes open for, wait for it, prolonged fever. And I have a sign up in the ED when you have a kid with 4 days of real measured fever and irritability. And I've never seen a Kawasaki's that wasn't pissed off. Keep it in your head. I just want to put that out there. We're not going to do much more with it than that, but we've learned nothing about Kawasaki's in 20 years, really. We don't have it nailed. All right, what about Alties, irritable infant? Who's a hospitalist here? Any hospitalists? I want to congratulate you for being lower on the food chain than me. Good. Okay. Somebody I can dump work on. I so respect it. I love hospitalists. We send all the Alties upstairs. We do. And it's very hard because in the light of day you get a better story and you get maybe the real parent shows up and all sorts of, don't get me started. It's the nuclear family is an illusion. Everybody knows that. I mean, if I get out of medicine, it's from the sociology, not the medicine. The medicine's wonderful, but the sociology is impossible. But Alties are scary, and parents will tell you, he stopped breathing 3 times today. Where were you the first 2 times he stopped breathing? Well, I went to Wegmans. I was at Walmart. We bagged him in Walmart. We put it. All right. So once upon a time, we admitted them all, and we didn't do a lot of workup. But this is a nice study backing up what we do, and the incidence of reflux in these kids. And you know it in your heart. You get the story. They do a Sanford posturing. They do sort of refluxing. But then the mother throws in the limp and lifeless part of it, the blue part of it, the look dead part of it. No, and what am I going to do in the ED? I'm going to say, I'm going to send you home, and I'm going to say, return for seizures, apnea, coma, and death. Keith, you have that in Epic? You have that smart phrase? Yeah. What are you going to do? So here's a badly blurred discharge plot for what these kids had. 50% had GERD, and that's the bottom line, but these kids need a bed because we have to counsel the family on how to feed kids. Now, when Dr. Ryan left me, we had 4,000 visits a year in my PZD, and we're up to almost 28 to 30 now. Should I be celebrating that? No. I am witnessing the death of primary care. 85% of what comes in my ED is in better shape than me. But it's life. But the reality is anticipatory guidance happens on every level, hospitalist level, ED, and whatnot. So GERD is there. Another thing about this was a freak out to me, and I know, Rita, you said something in passing. Accidental poisoning is ALTIs. They did a study of 600 kids with an ALTI, and they did tox screens on them. And I would never have done this. I'm with you. I was trained at Bellevue. If you got a tox screen and it was normal, you had to pay for it. They were pretty psychotic. Truly positives, 18%, and significantly worthwhile on 8%, and over-the-counters. People give their kids stuff. And what's out there? Sudafeds, antihistamines, anticholinergics, dysrhythmic type drugs, and they found you might want to look into it. It's a very interesting concept. If you look at irritability, we're talking about the crying infant. I learned something here. Everybody in PZM knows the following. Afebrile, irritable new baby comes in. He's got a corneal abrasion, an occult subdural, a choking mechanism, a torn frenulum, fractured ribs, a hernia, or some other malfeasance still proven otherwise. Well, you got to add something else to your list in your workup. They had 237 kids. This is a lot of numbers here. But let me just get to the point. UTIs. A lot of UTIs. And they found that you really were very, very rewarding by getting urines on them. I don't want to give you too much to read here. Sick kids are easy when they're irritable. I'm not going to get into that. They found some other labs were worthwhile, but in the end, it's UTI. So that's the take home here. I don't want to, it's too much numbers. So, and you get a very fussy kid, don't forget the urine. And that's really not in a lot of the books. We talk about the hernias and the fluorescein stains and the corneal abrasions and the occult trauma. What about viral gastroenteritis? How many of you in this room had a GI bug this winter? It's not an AA meeting, people. I had it. Anybody else? Of course you did. You're PEDS people. You're going to get you guys are a petri dish. Once upon a time, antiemetics were contraindicated. Compazine, phenergan, atropine. They had side effects more than antidiarrheal effects. Dr. Oski would have killed us if we gave somebody phenergan. I remember that. And then God made ondansetron. Here's a study that's so old, it's even 4 years old. How much are we using for this stuff for, Zofran? During the study period, 33,000 patients got it. 12,000 of those were not gastroenteritis patients. They had other things. The non-gastroenteritis patients were older, and they got it enterally, and most went home. But let's take a look at what we're using it for. Fever, abdominal pain and tenderness, head injury, pharyngitis, viral infection, migraine variants, otitis. In other words, anybody who's barfing, we use it. How many of you have Zofran in your home? Okay, smart. The rest of you should get it. Okay. Appendicitis, asthma, and pneumonia, and diabetes. So it's everywhere. It's so prevalent that the phrase, and we just got word of this, we patented, my PZM group, the term ZoPoGo, which you've heard that? Zo and Go? We give it in triage, Zofran, and they often come back. But what I want you to pay attention to is, I don't want you to forget the ultimate antiemetic. Cheetos. We have vending machines in my waiting room. We built a children's hospital, and they put Tim Hortons, which is a Canadian Dunkin' Donuts, Tim Hortons up there with a Cold Stone Creamery, where over 100% of the calories are from fat. And they stuck it up there just so the kids would just, but the Hemont kids need their cold ice cream. We won't get into it. But in my waiting room, we have all the vending. And Cheetos are my favorite because you'll read the triage note in the chart. It says vomiting all day, right? And then the kid will come back with a positive Cheetos sign. Eating. And you're done. Zofran and Cheetos. So for those of you who drink and party, there's a reason you want Cheetos at 2:30 in the morning. Take care of your stomach. I'm dying, and I can't get it through the IRB, to do a tox study where I compare the absorptive capabilities of activated charcoal versus Cheetos. So keep Cheetos in mind. All right, pyloric stenosis, appendicitis. Once upon a time, all infants with pyloric stenosis had Metabolic alkalosis, got a barium swallow. Once upon a time, all appendicitis had fever, anorexia, psoas sign, and elevated white count. This is what your mother and father told you. Olives. The peristaltic beauty of pylorics. I've never seen them. Never. I just can't, I'm never there. I give up. Amazingly, the surgical residents always see them. They're my role models. I hate them. No, I hate them. They're idiots because they want to scan everybody. You fight the scan battle with bellies? You guys fighting it? I hope you win. It's not funny. All right, this is not fair either. Clinical presentation of pylorics. What's happening? What is your generation faced with? Olive only 13% of the time. Not good. You're not going to see it. More importantly, the labs were not there, but that makes sense. It's a spectrum disorder, and this is because we ultrasound people now, and that's the take home. Just get an ultrasound. I never argue with that. It's not that expensive. I often consider myself training the ultrasonographers to get findings and do better, so they do it. And what about appendicitis? There's so many articles on it, it's not helpful. Well, guess what? Atypically, in this study, 80% didn't have fever, no Rodstings rebound, all this stuff. I don't know what to believe. I am so old that if you had a belly pain baby, kid, I would get a white count and examine them. And if I was on the fence, I would send you home for 4 to 6 hours, have you come back in, repeat the white count, and re-examine you. And my sensitivity and specificity were good, plus I had my graduate. But we didn't do all that. Now we just jump. So is your sonography reliable for abdominal pain? I talked to Keith last night about it. Syracuse, we have an 80% false negative rate. It's good. And they still charge. Any radiologists here? Anybody? I really hate radiologists. We talked about it last night. I detest them. They call back 2 days later with a reread. You know what they do? Here's what I want you to do when they call you back and they said, we looked at this with my attending. Because they were obviously fighting the Iraqi conflict for 2 days before they got to the film. And you'll say, oh my God, I wish I would have known that. We just pronounced them. Oh my God. It's too bad you didn't. Clearly, I need to retire. Child abuse, I don't want to bum you out. We used to, with the dolls, remember the dolls? Celeste loved the dolls. We don't do a lot of this stuff anymore, but things I want you to pay attention to is that. Skeletal surveying. And illicit drug exposure. These are just two titles. These are the kids you must skeletal survey and you must get a drug screen on. These articles will back me up. I don't want to dwell on the data. What about foreign body ingestions? A brief word. All ingested foreign bodies, if they were below the crike level, they were observed at home. Well, sorry people, the new recommendations are disc batteries have to come out that night. End of story. They can discharge their lithium carbonate, and that's a non-discussion. Whoever does it here, ENT or GI, get them in. All right, a couple of quickies and we'll wrap up. Cool new signs and procedures. This is my favorite sign. The red umbilicus. A couple of crazy GI guys in Italy had a bunch of cow's milk protein sensitive babies, little guaiac stool, irritability, maybe some eczema, and they noticed that they had red umbilical tinting. Not an omphalitis, people, just a little redness to it. It's a great study. They then put them on a cow's milk elimination diet, and the redness went away, and then they re-challenged them with the cow's milk, and the redness came back. Oscar would have loved that. I have no idea what you guys do with this. We're done. All right. Nasal foreign body removal. This is important, please. Keith, you have the CATS extractors. Do you use these? Hidden. Yeah, we have to hide them too. These are Foley's. And just get this thing. It works beautifully for the nose. Not so good for the ears. All right. What about putting the elbows back in place? Old school is flexion and pronation. This is hyperpronation. Everybody's got their way to do it. Nursemaid's elbows are the most rewarding things in the PGD that we can do. People are better, and first time you look good all night. So there's a couple ways to do it. And then Bob Cantor did this study, my colleague, about the femoral sticks. Now, we used to do femoral sticks a lot, and they can be very maddening because you're over the vein, but you got red blood. Or you're over the artery, but you get darker blood. You don't know what's going on. Well, big surprise, somebody did a sono, And 1 out of 10 people have them right over each other, and 1 out of 20 have them next to each other. So nice thing to know, it's not you, it's the body. Keep it in mind. But at 4 in the morning, and you want to get some blood, I don't care what I'm hitting. I'm going for the ventricle. That's it. All right. No. Changing philosophies, and we'll wrap up. Number 1, what do people want you to wear? What do they want you to wear? So they did this study, and I have the male counterpart. First of all, I don't want any of these people touching me, but kids voted for this one. All right, I'm done with that. Parental procedures, parental presence. Take a look. Tons of articles favoring it. I'm sure, Keith, you let him in the room for CPR. All right. Why don't you want a mom or dad in the room when you're doing a procedure? Why don't you want them there? Well, you're secure, but don't you want them there? Why wouldn't you want them there? In case you mess, thank you for being the only honest one. That's right, because you will mess up. It's like, if you were, busy making love to someone, would you want me to bring in a porn star to critique you? Come on, you don't want any reviews on site. So how do you get rid of a parent? Because if you want to, I have a simple way. I always say, listen, it's perfectly within your purveyance as a parent to stay. It's your right, and I endorse that. But know this, if you stay, the odds of me screwing up go way up. And if you can handle that guilt, you stay. Okay. Child Life Services, give early money, give a lot. They're more important than the doctors. And nobody's more important than nurses, but they're more important than the doctors. They are the best. They are the standard of care. AAP policy, I know you got one from who paid for it, the telethon probably or something. I can't say enough good things about Child Life people. They really are there for the right reasons. And then painful procedures, we shouldn't hurt kids anymore. We just shouldn't. If there's a hole in the body, we're going to find a way to put a drug in it, except odically. And we are sedating the hell out of everybody now, and it's a pleasure. Butane is done. We take care of kids, and you shouldn't hear a lot of screaming in the ED. I'm preaching to the choir here. So I'm going to end with this. Obviously, I have no frontal lobe left. It's gone. No, it's gone. And yet it's true that any of you in medicine have to be careful with the stories you tell. I remember when you did NICU, you couldn't tell some of the crazy stuff from the NICU to normal people, right? And like if I'm out at dinner with like civilians, I just refrain from telling stories because you can tell it's not going to go well. But every once in a while you tell somebody a story and they say, oh, that can't happen. That couldn't, or it's never too late for a child. And you go, yes, it is. It's like, so life is stranger than fiction. And some things are just true. This unfortunately happened. See, I'm Jewish. We knew this. We didn't want to tell you. We take care of the grave. We don't. All right. So I cleaned this up for that word. These are true stories, and it changes. I just keep changing the slides from real stuff. Most interesting chief complaints that I've heard. My baby needs a circumcision because his tonsils and adenoids are so big. I can't find my baby's birthmark. You're laughing. Now, new moms, say what you will, they're getting younger. They're getting younger. They are maybe not the most highly educated, whatever, and they're certainly abandoned within 20 minutes by the baby daddy. But I speak out of turn. They are expert dermatologists. They know their child's skin impeccably. They stare at the most gorgeous thing that God has given them all day, and they know every skin mark. If you say to a mom, whether she's 8th grade level or college, does the baby have any birthmarks? They know every speck, and they're the best. Can you imagine if they missed a birthmark? It was gone. I had a lady who actually looked in her pocketbook. I said, where do you think the birthmark went? She goes, I don't. All right. Place tooth under pillow now lodged in right ear. Problem with his manlyhood. My baby's afraid of his hands. Needs anus muscles checked, has been straining. Now, in fairness, I tell the parents to go home, lay on their own bed on their back, and look in the mirror and simulate the Valsalva activities and see if you strain. There's a reason we sit. The poor baby can't. I need a swine flu test. I haven't been to Mexico, but I always eat at Taco Bell. These are real stories. What about other chief complaints? I fell out of infancy. I have a lump in my tentacle. I need a mental extraction, and I have romantic fever. I have cerebral palsy, sick as hell anemia, scrap throat's bad. You don't want scrap throats, and you definitely don't want swollen asteroids. And I have a new one for you, Rita. Remember gestational diabetes? It's been changed to gas station diabetes. 65 Brewster, cystic fibrosis, okay? It's a very old one, very old one. All right, what else do we got here? We got phone calls. Hello, is it busy? I'd like to schedule an emergency. How many of you, tell the truth, have picked the phone up in the ED and somebody says, is it busy? What do you say? I go, it's Armageddon. Dogs sleeping with cats. There's blood everywhere. I'd go to the other hospital. Do you carry breast milk? May I speak to Dr. Zithromax? My baby stopped breathing a few times. What time can I bring her in? Is it all right for a 2-month-old to play if he's constipated? Is there such a thing as a birth control vibrator? There should be. I was beating my daughter with a belt and I hurt my hand. Sorry. Do children born microcephaly have headaches? And the last one is, should a 5-year-old child be wiping his own butt? This is true stuff. So that kind of wraps it up. So this is the life we lead downstairs. So don't hate us for being bizarre. This is the real life. I can't tell you how you've been a good group of people to talk to, except a couple of guys in the back who need oximetry. But it's not your fault. You got a nice facility down there with good people. Be nice to your PDM people. But most importantly, and I always say this and I mean it, anybody who takes care of children is doing God's work. Anybody who never asks for more money, never screens what the hell they're doing, and just says, hello, I'm Dr. So-and-so, how can I help you with your child? You're blessed. You're privileged. You have a skill set. And I'm happy to get up in the morning and do what I do. It's really weird. I hope you have that for as long as I have, because in the room, no matter how much I hate the night in the ED and I hate my life and I hate the world, in that room is somebody else who doesn't want to be there, and that's the kid. So keep doing what you're doing. Be nice to Dr. Ryan. And I thank you for your hospitality. Thank you very much.